everyone, I'm Dr. Neel. Welcome to Sushruta LGS. In today's video, I'll be talking about nerve compression syndromes. So in upper extremity, we have three important nerves: median nerve, ulnar nerve and radial nerve. All these nerves, they pass through a number of anatomic bottlenecks. Hence, all these sites are possible sites of compression of these three nerves. So when these nerves are compressed, it leads to distal sensory and motor deficit. So in the next two slides, I'll be telling you about the most common sites of nerve compression. I've just enlisted them and I'll be elaborating a few of them today in this video and rest of them in the upcoming videos. Okay. So proximal to distal, when we go, nerve roots, that is C5, C6, C7 till T1, the brachial plexus, these new roots can get compressed by cervical disc disease or cervical degenerative arthritis. Okay. Second important is thoracic outlet compression, which can occur at the level of clavicle. Third, at the elbow, ulnar nerve entrapment can occur, which is a very important syndrome known as cubital tunnel syndrome. Then in the proximal forearm, there is entrapment of the posterior interosseous nerve, also known as radial tunnel syndrome and posterior interosseous syndrome. Entrapment of median nerve and its branches can also occur in the proximal forearm, known as Pronator Syndrome or anterior interosseous nerve syndrome. Okay. Entrapment of median nerve can occur at the wrist, known as Carpal tunnel syndrome, which is the most common syndrome of all. And lastly is the ulnar nerve. It can also get compressed at the wrist in the Guyon's canal, known as ulnar tunnel syndrome. So what are the causative factors? In most of the cases, there is no specific aggravating causative factor. It generally occurs due to chronic repetitive stress, okay, like few assemblers or chicken cutters. So when there is chronic movement of the wrist, it can cause carpal tunnel syndrome or it can cause ulnar nerve syndrome. Then trauma, so bone compression in carpal tunnel after carpal dislocation or carpal bone fractures, the median nerve can get compressed in the carpal tunnel. Or when there is distal radius malunion, again median nerve can get compressed. Or in supracondylar humerus fractures, it alters the elbow carrying angle, so which leads to compression of the ulnar nerve at the elbow. Synovial thickening of the bursa, okay, that is rheumatoid arthritis in the carpal tunnel. Again, any kind of inflammation can cause compression of the median nerve. Or similar thing in the elbow, posterior interosseous nerve can get compressed. If there is any tumor present, like giant cell tumor in the Guyon's canal, it can compress the ulnar nerve. Okay. Or if there is a lipoma in the radial tunnel, it can cause posterior interosseous nerve syndrome. Anomalous muscles, like few muscles present in the carpal tunnel or Guyon's canal or forearm, they can compress median or ulnar nerve. And similarly, disturbances in fluid balance, it can cause increased pressure on the nerve, like in myxedema on pregnancy, it can cause carpal tunnel syndrome. So coming to today, I'll be covering mainly about median nerve. So two important syndromes associated with median nerve are carpal tunnel syndrome and pronator syndrome. Carpal tunnel syndrome is the most common syndrome and most commonly the nerve which gets compressed is median nerve in carpal tunnel. So before going to the syndrome, you should know what is carpal tunnel. Carpal tunnel is a fibro-osseous tunnel which is present at the wrist. Okay. Median nerve, it passes under this fibro-osseous tunnel. Carpal tunnel's roof is formed by the flexor retinaculum. You can see in this picture. So this is the flexor retinaculum, or also known as transverse carpal ligament. So this is the roof of the carpal tunnel. Floor is formed by the carpal bones. As I told you before, any carpal bone fracture or dislocation can also cause compression of the median nerve. Okay. So this is the carpal tunnel. Again, in the picture here, you can see this is the flexor retinaculum. These are the carpal bones. Okay, and these are the structures, tendons which are present in the carpal tunnel, and this is our median nerve. So median nerve can get compressed in the carpal tunnel. Normal pressure in this tunnel is around 20 to 30 millimeter of mercury. So any rise in pressure above this can cause a chronic compressive ischemic injury to the nerve segment. Okay, initially there will be demyelination, and if not corrected, in correct time, it can lead to axonal death. So what will happen if there is demyelination? There will be progressive conduction block in the nerve, and there will be sensory and motor dysfunction. Initially, always patient complains of sensory disturbances, that is pain and paresthesia. So where does this pain and paresthesia, where will it occur? It will occur in the distribution of the median nerve. So median nerve, it supplies our thumb, the index finger, middle finger and radial half of the ring finger. So this part of the hand, there will be pain and paresthesia. Okay, and this pain, paresthesia, numbness, tingling, it will be more obvious at night. It will be more after prolonged activities or postural changes in the wrist. So patient will have clumsy movements and there will be tendency to drop objects. So initially when ladies come, they complain that first of all there is pain, paresthesia in this distribution. Secondly, they tell us specifically that they are not able to hold, whenever they hold object, the utensil, it slips from their hand. So this is a very typical feature you will see in females. Okay, so now this was about clinical examination, the clinical features. Coming to the examination, how can you diagnose it? So there are three important tests. First is the Durkin's test. So by compressing the carpal canal, okay, there will be again the pain, paresthesia, numbness, it will increase. So in this figure you can see this is Durkin's test, compressing over the carpal tunnel. Okay, patient will complain of pain and paresthesia over these fingers. Fine. Second is Tinel's sign. Tinel's sign, you percuss over the root of the median nerve. So you percuss over the carpal tunnel and patient will complain that there is some kind of current going through the distribution of the median nerve. And one very important test which you need to remember is Fallon's test. Okay. So Fallon's test is hyperflexing of the wrist. This is known as Fallon's test. It will compress the carpal tunnel and patient will complain of pain. This is Fallon's test, and Namaste sign is reverse Fallon's test. So in sensory evaluation, hypoesthesia, pain, paresthesia, numbness, okay, and there will be widened 2-point sensory discrimination. Motor evaluation, as I told you, that is a late feature. Initially, patient will only complain of sensory disturbances. If not treated, it will lead to thenar weakness or muscle wasting. Okay, and finally, the most important test by which you can prove that it is carpal tunnel is nerve conduction studies, and electromyography suggested to the patient will finally tell us that this is carpal tunnel syndrome. Management, initial treatment is wrist splintage, which is given at night. So this is the splint which I have shown in the picture. Okay, we give local corticosteroid injections. Scanacort 40 mg injection is given. It gives good relief to the patients in the initial stages and modification in work patterns. If our non-surgical conservative management does not work, if patient still complains of symptoms or if the severity of the symptom increases, then you have to go for surgical decompression, where in surgical decompression it can be done by both open and endoscopic means. We longitudinally divide the flexor retinaculum and we release the median nerve. If there is any mass or any lesion, if it is there, it is removed, synovectomy is done and median nerve is kept free. So it can be done both by open and endoscopic means, which is again by endoscopic it can be a single portal method or two portal methods. So just remember the names. Okay. Both are equally effective. None is superior. It's just that by open method you will give an incision of around 4 to 5 centimeter. By endoscopic means the incision is very small just for the scope to get in. Second important syndrome is the Pronator Syndrome. In Pronator Syndrome, the median nerve gets compressed in the proximal forearm. So there is a fibrous arch which is present between the two heads of the pronator teres. So you can see this is the humeral head of the pronator teres and the ulnar head of the pronator teres, or it can get compressed between the two heads of the FDS, or it can get compressed beneath the Lacertus fibrosus, which is the bicipital aponeurosis at the elbow, or ligament of Struthers. Now ligament of Struthers, you can see it is a fibrous band which is present from the supracondylar process, which is a bony spur, and it gets inserted to the medial epicondyle of the humerus. So ligament of Struthers, when the median nerve passes, this is the median nerve which is passing underneath the ligament of Struthers, so it can get compressed. So this is known as Pronator Syndrome. Now people generally they get confused between two terms, that is arcade of Struthers and ligament of Struthers. Ligament of Struthers, as I said, it is a fibrous band which is present between the bony spur supracondylar process and the medial epicondyle, and it will compress only the median nerve. Whereas arcade of Struthers is also a fibrous canal which is present on the medial aspect of the arm in the mid and lower third of the humerus. Okay, so it is formed by the aponeurotic system of the medial head of the triceps and also the medial head of triceps, which gets inserted into the intermuscular septum. So again in this picture, this is the arcade of Struthers which you can see. Okay, it is getting inserted into the intermuscular septum, and this is the ulnar nerve which is seen passing underneath the arcade of Struthers. Okay, again this photo, this is ligament of Struthers, whereas this is arcade of Struthers. Okay, and this is the intermuscular septum. It is getting inserted into the intermuscular septum, okay, which is formed by the aponeurotic system of the medial head of the triceps. So arcade of Struthers, it compresses the ulnar nerve. Ligament of Struthers, it compresses the median nerve. I hope these two terms are very clear to you. So again, what symptoms you will have? You will have same symptoms as carpal tunnel syndrome, but at the same time also you will have palm numbness, and the entire palm will be numb, okay, because the palmar cutaneous branch is also involved. Now we'll tell you how the palmar cutaneous branch gets involved. For that you need to know a bit of anatomy of the median nerve. Okay, so in this picture, as you can see, median nerve, it is formed by C5, C6, C7, C8 and T1 roots. It passes through the axilla and the arm. In the axilla and the arm, just in short, I am telling you the anatomy. Okay, in axilla and arm, no branches are given to any of the muscles. At the elbow joint, it starts giving branches to pronator teres, FCR, palmaris longus and FDS. Okay, then is formed the anterior interosseous nerve, which gives branches to the deeper compartment muscles of the forearm, that is the FPL, the FDP of the lateral half and the pronator quadratus. Okay, now you will see there is the palmar cutaneous branch. So the palmar cutaneous branch is given approximately 4 cm proximal to the wrist. So that is the reason why palmar cutaneous branch is not compressed in carpal tunnel syndrome. First of all, it is given proximal to the wrist, and secondly, it passes superficial to the flexor retinaculum. So that is the reason you do not see any palm numbness in carpal tunnel syndrome. And this is the feature which differentiates between pronator and carpal tunnel syndrome. Again, the management is surgical decompression. Okay, you have to release all the 4 potential sites of compression, as I said, between the FDS, the pronator teres, the ligament of Struthers, and finally the bicipital aponeurosis. Okay, anterior interosseous nerve can also isolatedly, it can get compressed. Okay, it is a branch of the median nerve, as I showed you. It specifically targets only 3 muscles: FPL, FDP of index and middle finger, and pronator quadratus. So this is about pronator syndrome and about carpal tunnel syndrome. Carpal tunnel syndrome is the most important syndrome which you should know about. You should know about the Fallon's test. You should know about the sensory distribution of the median nerve. Okay, you should know how to differentiate between pronator syndrome and carpal tunnel syndrome. I hope I have made things pretty clear to all of you, and if you have any doubts, you can reach out in the comment section. Thank you.